everybody. John Kublank here. We have another great episode of Off the Cuff, all things healthcare. I am honored to get to share a screen, this country, with such an amazing host. She's really the reason why this all comes together. She does so much to help us out. Miss Arlene Maxim, how are you today?
I'm good, John. Thank you so much. It's just always an experience to find out how I'm going to be introduced every Wednesday. Thank you so much. Yeah.
No, you deserve every word. How's Florida? Looking nice today?
Well, actually, you know what? It was 60 degrees when I got up this morning. It was cold. I opened the doors and I shut them really quick. I've really gotten used to this Florida weather, so it's really difficult when it drops below 80 to even tolerate the weather. So, but it's actually quite lovely right now. It must be in the high 70s, and it's nice. So, thank you. Yeah,
And Arlene, we have an amazing guest today. We've been really excited all week, and even from last week, which we had a great show with Officer Manis. And to come off of that episode right here, we're really excited. So can you introduce our guest today?
I would love to introduce our guest. Zaundra Ellis is a colleague of mine and also a personal friend. And Zaundra is known as an expert in the hospice world. If you've been to conferences and not conferences, a number of state conferences in California, New Mexico, Texas, and probably another number of other states, you've heard Zaundra speak. And she's just an absolute incredible wealth of information on hospice. And we are so happy to have her here today and get information about these new programs that are being spun off by CMS into the hospice world. Of course, the Special Focus Program, no one has ever experienced before that I know of. And so that's going to be a shock to the healthcare system. And then we're also going to talk a little bit about palliative if we have some time. And that's kind of a new, not necessarily new, it's been around for a long time, and everybody has a different definition of palliative care. So we're hoping that Zaundra is going to shed a little light on that for us and give us an opportunity to ask some questions. I would encourage everyone on the line right now to type in questions in the chat, call in. We're happy to respond to any questions that they might have. And Zaundra, again, I'm just so happy to have you here today. Thank you so much for taking the time with us.
Hey, Zaundra.
Well, you know what, Arlene, it is my pleasure to be here and so much fun. I'm excited, to participate. It's kind of a heavy topic, but, something that we really need to talk about. So, and I don't know that Arlene knows this, but prior to joining hospice, I was a nursing home administrator for many years.
Oh, wow. Okay.
So nursing homes have had the same program in place for a while.
Yeah, and that's what we were talking about kind of prior to the show. Hospice has kind of been left alone for so many years. 1982, 1983 is when the sort of Medicare benefit came into law, right? 84 or something like that. But every year they're increasing rates. Like, that's been the kind of behind the scenes for the executives, whatever, like, oh, yeah, increase. But since like 2018, we started to see a lot more scrutiny over hospice, finding ways to cut reimbursement without actually cutting reimbursement. And this SFP program looks, even though it was at 2022 that it was proposed, now it's going to be actually implemented in 24. And it is what is going to be a, sequestering of finances at some point, right? That's how they'll penalize it.
At some point, yeah. And so I think what's really interesting, during the pandemic, there was an explosion of new hospice organizations, right? We saw it most in California. And unfortunately, some of those were kind of shell organizations, right? That were used to, fraudulently bill for patients that they didn't have, for staff members that they didn't have, bill Medicare and get paid for it, right? So we had this huge explosion. And then we just had folks that were just buying hospice they were creating, people have been doing it for a long time. Let's get a license and sell it. Right.
And that's being changed too now, right? They're adding a 3-year rule, correct?
Yes. And so, those things combined kind of created a perfect storm. right? With real data from CMS about, and the OIG and all related parties about how the Medicare Trust Fund was being drained by, these activities. And so what we know, it kind of started in California, now it's kind of drifting east. And a lot of this is kind of in response to that, right? Because now, the light is on and people are like, oh, wait, not all hospice people are in it for the right reason, right? We've got a lot of bad actors out there who are, defrauding the Medicare Trust Fund. And so regrettably, in some ways, this is really deserved, right?
Yeah.
And it's one of those things everybody has to pay for the sins of a few.
Yeah, it was just like general debility when I first started, right? That's one way it's made it harder is they looked at diagnosis LCDs like, hey, we're overusing this, levels of care, we're overusing this, right? But now it really is just about quality metrics. And they're going to be using 10, 11 of the COPs to measure for us. What are some of the ones that stand out to you that are going to be areas where the agency can really have an impact from your perspective?
So I think that when we look at the quality of care conditions that they're looking at, right? I think patient rights, that's fairly straightforward, right? We're talking about staff training, patient and caregiver training. That one's pretty straightforward. And I think, initial and comprehensive assessment of the patient, it's always, interesting to me that there's confusion about those things, right? So I did the initial or I did the comprehensive, but I never did an initial, right? And it's really about doing both or combining them. I think what's really going to trip people up quite a bit is the interdisciplinary group care planning and coordination of service, that condition level, right? That's really tough because care planning affects everything, right? And then we look at infection control, that's really kind of a big one. And then hospice aid and homemaker services. So if you look at the interdisciplinary group, the care planning and coordination of services, infection control and hospice aid and homemaker services, that almost covers everything that's provided for a hospice patient, right? So really looking at those things, those processes, individually within your organization is going to be imperative. And, it's a 3-year look back period, right? And so, I always suggest when you're getting ready for a survey, look back a few years, see what you got cited for before. If you had a plan of correction, make sure that you are still following that plan of correction, right? And then if that's closed, that we're following it in QAPI, right? So now that's not really a suggestion. It should be standard operating procedure for hospice organizations. Let's look at our survey history. So, hospice providers today need to go in and they need to look and see what's happened over the last 3 years and see if they could be identified as a participant for could they be selected for a special focus program, right? So that's the first thing. The second thing is look at those specific quality conditions of participation and make sure that you have it locked down. And the most important thing that hospice organizations and leaders should do, and for me, I think it's kind of low-hanging fruit. There's always opportunities for improvement, right? And so really being tuned into what's going on in your organization and understanding, we were talking a few minutes ago, right? Ms. Smith calls at 3:01 in the afternoon and says, Mary was supposed to be here at 3:00 and she's not here, right? That's the kind of detail of concern or issues or opportunities for improvement that organizations really need to be focused on, right? And that's just on the patient side, but we also need to look at our documentation, right? And our processes. We got to be sure our policies and procedures are airtight and that we're following them to the letter of the law, because even if you're doing all the right things, right? Let's just say
or have the right intentions.
Right. Well, you're doing all the right things for the, for regulatory, right? So I'm doing all the right things according to the conditions of participation. But if a surveyor comes in and they open your policies and procedures and, they are more stringent than the conditions of participation, they're going to tag you because you're not following your policies and procedures, right? So it's really kind of, I hate to say this, but a little bit of luck, a whole lot of strategy, and lots of elbow grease, right, is going to have to go into this. But I think kind of going into it as organizations delve into it, they can develop best practices and SOPs as they move forward. But right now, it's a little bit of a mad scramble.
Zaundra, can we back up just a minute? Can you kind of go over what the Special Focus Program is? Like, what's an overview of the Special Focus Program? I'm expecting that there are a number of folks on here that don't know what that is and haven't even heard about it yet. So if you could just kind of summarize it for us, and then we can talk more about some strategies to make sure that we're in good shape.
Yeah, so absolutely. So the Special Focus Program is designed by CMS to help them identify hospice organizations as poor performers based on defined quality indicators, right? And CMS will select hospices for increased oversight to ensure that they meet the Medicare requirements. So poor performers are going to be identified in Q1 of 2024, and that's going to be based on data from calendar year 2023 and prior. So a 3-year look back, right? And so really what they're looking at is they're looking at condition level deficiencies related to quality of care. They're looking at substantiated complaints. They're also looking at the hospice care index scores and CAP scores of the organization. So they have kind of a complicated algorithm, right? So it's going to be lots of hands on deck to get it figured out, even for CMS, right? So, we talked a few minutes ago, this has been brewing for a couple of years now, and they finally implemented it. And I think that when they're looking to identify this, I guess, bottom 10% of performers, they really are looking at it's all encompassing, right? However, the way the algorithm is designed, an organization that has 300 hospice patients, right, that gets one condition level deficiency, and the hospice that's just starting, right, that maybe has 5 or 10 patients, they get a condition level deficiency. They're both going to be considered when the algorithm is applied to be included in this special focus program, right? And we know that the 300 patient hospice, they're providing a lot more services, right? There's lots of opportunity, for them to do the right thing or for them to misstep, and miss something that would cause them to have a condition level deficiency, where the smaller organization, it would be glaring. But if I had 20 patients, it would be a lot easier for me to make sure that I don't have a condition level deficiency issue than if I had 300 patients. Does that make sense?
Oh,
Yeah.
sure.
Well, and I think it also goes to at 300, you have the labor. Are you training? Are you onboarding correctly? When you have these sharp increases in census, or you're growing too quickly, your onboarding definitely goes downhill, and you start to miss out on stuff. I remember, not in hospice, but a survey for a facility that I was working with as a partner. They had state come in, and one of the aides didn't know where the AED machine was.
Mm-hmm.
That was a J tag. You know what I mean? Like that was serious, and it was all due to orientation. And not that she didn't get the orientation, but like you said earlier, 3:00, 3:01, can we do something better? Is there something we can do? And if we're not looking at every single process and procedure from orientation all the way through, you could be risking a lot in the long run versus saving money in the short run. Get them out there, go get them patients, let's go. And then your HIS is all messed up, or, like you said, the initial plan of care, something is not right.
Right. Yeah, I think that's funny. I had a 14-bed inpatient unit for hospice, and we had a surveyor come in and stood by one of the fire extinguishers and was asking people walking by, "Where's the fire extinguisher?"
Yeah. And if they could, that would be sad if they wouldn't see that one. But at the end of the day, some of them are not even nice. They might sit on the other side of the building and say, "Where's the fire extinguisher?" Right. At the end of the day, we don't know what surveyor is going to come in, what their attitude is. Do they have an upset stomach? Do they have a good lunch, bad lunch? Did their boyfriend break up with them? Girlfriend break up? Who knows? Right. So we better have everything put together and not leave as least a chance as possible.
Right. And that's one of the things, when the technical expert panel convened to discuss this special focus group, that's one of the things that they really expressed concern about, is not only just survey inconsistencies from state to state, but also surveyor performance.
Yes.
Right. And so, we've all been doing this a while. And so sometimes somebody wakes up on the wrong side of the bed, and the hospice organization pays the price for that, right? So I think that, it's a really good point to tie into what you said, John, is, survey management is so important, right? And so being prepared, knowing your business, having a relationship with the local licensing director, right? So if something does go wrong with the surveyor, you have an issue that you have, a resource to go to, right? And really kind of that, let's do this together approach, right? They're not the enemy, even though they kind of are. They can't know we feel that way.
Well, it's interesting because I've done conferences in a number of different states, and I've got to tell you, when I was at the state of Utah, and I did a keynote there a few years ago, and the surveyors there were just the nicest people, and I was shocked at the difference in personalities of them compared to some other states I had been in, and I met some of them, and they're almost antagonistic sometimes. But we can't use that as an excuse either. And I think that sometimes that happens, that we use the surveyor's response to different things as an excuse, that we have responsibilities. And Absolutely. I think that we need to make sure, and first of all, we need to make sure that we're meeting those responsibilities, and now they've got the opportunity to do the IDRs. So based on whether if they disagree with a citation that was issued, they have an opportunity to write that redetermination up. But the issue about the surveyors, I think we have to be really, really careful about how we make it that determination that it was the surveyor's fault and it wasn't our fault. We've got to make sure that we think about ourselves. We look internally and think about ourselves. My concern is, and I know that the OIG and that report that they put out recognize that there were a number of immediate jeopardy findings with hospice. And as I think you alluded to just a few minutes ago, that, immediate jeopardy doesn't mean that there has had harm happen to a patient, but there's a potential for harm. And with hospice patients are so vulnerable, and there are so many things that could go wrong, that I think that's even many times more difficult than even in home health to be aware of and make sure that we've covered all the bases and we don't have an immediate jeopardy situation in place.
Absolutely. And you're right. So, it's never the surveyor's fault, right? It's the organization's responsibility to, meet the standard and to also, develop a relationship and a rapport so that, you don't get to the point where you're getting a condition level deficiency, right? So, I will say the OIG report was a very small sample. And when you look at hospice, Medicare certified hospice organizations, by and large, I believe, and I have the number here, I believe that when CMS looked at this and was designing the Special Focus Program, they did a 3-year look back themselves, and almost 89% of hospices, Medicare certified hospices, did not have a condition level deficiency.
Mm-hmm.
Now, that doesn't mean they didn't have deficiencies, right? It
Right.
just didn't rise to the level of,
It said 88.3%, I think,
Yeah.
was hospice with no CLDs.
yeah. So,
But do you think that was a result of hospices, like we talked about earlier, flying under the radar for so long, and so surveyors actually didn't dig as deeply into records and documentation? I was again at a conference another time where I was listening to somebody from one of the MACs speak, and they said, as long as we see in the visit notes that the patient, the issue about the patient's eating tendencies and weight were addressed, we don't really worry about too much else in the documentation.
Well, pain
now,
and
that's
bowel.
2 years ago. That's
Yeah.
been a while ago, but
Yeah.
I mean, I do think that they have not paid attention and have not cited us on some things that home care has been cited on for 25, 30 years. And I think that now hospice is going to have a significant wake-up call over the next few years. And
So I would say, Arlene, when you look at the state operations manual for home health and for hospice, hospice is more than double the number of pages that home health has.
Mhm.
Now, home health has been under a lot of scrutiny since the late 1990s, right? When everything kind of blew up. And I think my experience with hospice surveyors has been, you're taking care of people at a very sacred time in their life.
yes.
You better have it right.
Mhm.
Right? And they're very protective of those patients. So
Yeah, I've never had an easy surveyor.
never had an easy surveyor, and they're looking to make sure that patient and their family have the best end of life experience, right? Of course, they're looking for abuse and neglect and just good care,
Sure.
right? But I think, I think where kind of the rub is, and I'll use wounds as an example, right? So for home health, we want to get those wounds better, and we want to get them on their way, right? And a lot of times I think hospices think, okay, the patients have wounds, we kind of need to manage them, right? We don't want the patient to suffer at all. But, that's one of those things. If the patient had, a cold or a flu, we would absolutely treat that, right? And so if they have wounds, we need to be treating those wounds.
That's right.
And I think that's where, there's a little bit of a rub is, how are we maintaining their quality of life, right? And at the same time, we're not curative. That's the definition of hospice, but it's not an excuse, right? To let somebody develop wounds or have wounds that you're not actively trying to make that better, because that's a comfort measure, right?
Right.
And, some of the OIG kind of really focused on some of those wound issues. And I think, that's one of those things in hospice that has been a challenge for a while. And, I think that this,
Well, especially when you're talking about money, because wound care is typically out of formulary, out of the norm of what you're buying, and very expensive. So if you have very tight grip of your finances and you're not willing or have the ability to move from one place to another, it limits your availability of care or your availability of who you can take, right?
Right.
And that's not really an excuse. We as hospice, there's plenty of money to take care of a wound. It's just we have to be very diligent about our finances.
Right. And I think once, hospice professionals and providers who have had a general inpatient that had like a standalone inpatient unit that have cared for patients, and have that wound experience where you actually do wound vacs and you do, different kind of modalities that you see more often in home health or acute care. I think that's where the learning curve kind of happens. But moving forward, I think that we need to really look at those things, and wound care is just one example, right? And how do we make sure that, we're providing the highest quality of care, making sure that the patient is comfortable and that we're really preserving their dignity, right, at the end of life.
And we talked a little bit before, and you brought this up a minute ago, patient satisfaction. We know that the CAP scores, right, patient satisfaction, we understand that, we do everything that we can. Good hospice do everything they can to make sure their patients, their families are well taken care of. But statistics show that only about 29% of people actually return the CAP survey. And in my experience, this is anecdotal, but anybody that fills out a survey, at least a majority of them are angry about something. Why else would you pick up the pen and report, right? So there seems to be, this sort of weight on these satisfaction. And then I thought you brought up a good point, and I'm gonna let you bring up here, that, patient satisfaction at hospice is not always straightforward, and it's maybe more complicated. And maybe we should look at and suggest to CMS of a different way to do the survey.
Yeah, absolutely. So when you look at the algorithm for the Special Focus Program, the CAP scores count twice, right? The index that they use for CAPS is ×2. So that's kind of heavier than anything else that we're really looking at. And so, it's always been a struggle to get a good response. And we're asking people at a difficult time, hey, fill this out and tell us how much you like us. And, sometimes they can't separate their emotions from their experience. I would say most of the time. Yes. And the other thing is right now, John, I don't, when my dad died, I got this huge packet, of 20 pages of questions to answer. Nobody's going to do that. The people who are angry are going to do that, but
even still, it's like fatigue at that point. And you're already emotionally drained. It's like, how much more can you do?
100%. You've dealt with the insurance, with the death certificates, with all the financial stuff. It's just extra. So, you can do phone, you can do mail now, but there is a program that CMS is testing out where the CAP survey is sent out electronically. They've talked about it for a couple of years. They're continuing to study that. And I really believe that there would be a much higher response rate if it was clicking, right? Because we're used to doing everything electronically. We buy our groceries, we shop, we bank, everything that we do is computer-based. So, and I do think that we would have, and Arlene talked about this a few minutes ago when we were chatting, I think I think it was Arlene, the consistency of the data, right? So if it's submitted electronically, then there's no need for someone to go in and enter it, which is what's happening now when the CAP survey is done by phone or by mail. That information is entered manually. Now, CMS oversees that, and CAPS providers, they have surveys, right, to make sure that the processes are in place to get the correct data entered into the system. But, that's one way that things could be better. And with the CAP scores having such a high value in the Special Focus Program, it's going to be a heavy burden for some people. Now, I will say that when we're talking about CAP scores, they're really looking at bottom box scores for help for pain and symptoms, getting timely help, willingness to recommend the hospice, and overall rating of the hospice. So it's not every domain. And what they're looking for are, if it's on a scale of willingness to rate this hospice, I think it's 1 to 10. if it's 6 or below, right,
Bottom bar.
that's going to trigger it.
Yeah.
So, that's going to affect your algorithm. So that's really, and we can't just focus on those things,
Sure.
but, knowing that those are the things that are being considered in the algorithm, I think really helps.
What do you suggest as an operator in the, that you've actually been in those shoes? How do we, as administrators, as directors of nursing, whatever, even case managers, how do we prepare our patients potentially for this survey? What are some of the situations you've gone through to help improve overall CAP survey when it comes time?
So I think the first thing is to make sure you have a comprehensive training, and CAP surveys is common language that you use with all of your staff, right? Because it's not enough for them to say, hey, you're going to get a survey, or the patients are going to get a survey, right? They need to understand the why behind it. This is no joke.
How it's going to affect your agency.
Yeah, this is no joke. It's a government program, so let's make sure that we're doing everything that we can. The other thing is really, we talked about that 1 minute of my person's 1 minute late for their visit. Really take that information seriously, right? We all have to have a complaint log, but do we have an opportunity for improvement log? So maybe that doesn't rise to the level of a complaint, but I always counted it as a complaint, right? And so every little thing, we take into consideration, we track it, right? We talk about it every month and say, okay, it wasn't just Miss Smith, 10 patients called and said that Mary was late for their visit, right? And so we see that pattern and we can correct it there. We also see, I'm looking at it from a QA perspective, right? Because people are going to call and say, I couldn't get any help, right? They were late getting timely help. And I think that letting patients know in the beginning, that there will be Medicare beneficiaries, that they will receive a survey, after care has ended, just informing them about that. Beyond that, like, you can't speak to it specifically, but what you can do is develop, according to the area that you serve and your patient population, meaningful questions, right? For the team to ask. And so I always found it really helpful. And I always got a lot of information from the chaplains and social workers that would go out, those people that have really skilled at listening, they could pick up on things, right? And then we could address it. But I also think it's important to address it at the patient level as well, right? So if we have one patient that is continuously complaining that people are late, we need to address that in their plan of care. We need to have a process in place to meet their needs, because that is specifically one of the questions on the CAP survey that are considered as part of the special focus group. So it seems like something really small, but it's an indicator of something larger. And so, we're very fortunate in hospice to really provide interdisciplinary care, rather than multidisciplinary care. So as we work together, we can have innovative ideas, right? And we have lots of ears, and we need to use our ears and our brains to really focus on care in general, but now the things that matter most to keep us out of a special focus program.
One thing that I wanted to mention, there was an article that came out a couple of months ago, and it was from a remote care monitoring company. And they were talking about hospice patients and about how the CAP scores increased with the frequent touch points. And we don't often think about remote care monitoring related to hospice patients, but I can see that as being a huge benefit. And this article is really, really good. And even the thing that you were mentioning about somebody being 1 minute late, if we have remote care monitoring, somebody at the office could be calling that patient at that 3 o'clock time point in saying, I'm here to talk to you until the clinician gets there whatever conversation they want to have. But there again, you're respecting their time and you're respecting their patient rights, and then also having those touch points where they feel that warm fuzzy stuff that we need to have when they answer those CAPS questions. And I think that the staff too, going back to what you were just talking about with the staff, I think they need to understand that this is actually, the CAPS score is actually a report card on them. And so oftentimes hospices and also home care agencies do not take the time or the effort to train the staff on what questions are even being asked. So they don't necessarily know what they're being scored on. And so I think it's like important that part of that orientation, part of the ongoing training for hospice staff has some degree of education on what is involved in CAPS.
Absolutely. And I love the remote patient monitoring, Arlene. I'm glad you brought it up because, telehealth in hospice is really, CMS's stance is it's person-centered care and you need to be right in front of them, right? Mm-hmm. So we do have some flexibilities right now, but I think there's lots of confusion about remote patient monitoring and telehealth. Right. And they're two different things.
Telemedicine, even, actually telehealth, is like that blend between RPM and telemedicine, where you're doing more social determinants of care as much as medical triage, right? Mm-hmm. Like, do we need somebody out there? I'm looking at you when I'm on the phone and they say, I'm hurt and it's a West Texas farmer, that could mean he's almost dead, I'm hurt, he's a tough old guy. Whereas, me, I'm on the phone like, ooh, I got a boo-boo, come over. And then maybe you could walk me through if we're laying eyes and I have more of a feeling that we're connected. So I agree. I think there's a lot of misnomers and we kind of all put it together in one and say, oh, we can't do it, or yes, we can, but it's not that easy.
Well, I thought about, cost savings here too, because how often, and I think it happens a lot, that you get a call at 3:00 in the morning from a family member and they're just absolutely sure that their family member is dying right now and they want you to get out there right now. Mm-hmm. If you had the remote care monitoring capability and you could actually see what was going on and maybe talk them down, offer them some suggestions about different medications they might try and that type of thing, that might relieve some of the mileage that right now the hospice organizations are paying for, and also the on-call situation. I just think there's a lot of benefits to technology, and I was in a meeting earlier today where somebody was saying that we've got to rely on technology. We are short-staffed in every part of the healthcare profession, and we are not going to be able to rely on just our staff and our ability to get staff to do what needs to be done. And I think that having remote care monitoring and having those types of technology sources available to us is going to be really, really important.
Yeah, I think any way to help improve your overall organization with little technologies like Invoke we've talked about, there's a number of them out there, but I think one of the hard parts in home care that I've seen, and we're changing, is that, we're very reluctant to adopt new technology or take on any sort of CapEx that's going to not be reimbursable, because we're afraid that, if we kind of get outside of these lines, we're not going to be able to make revenue or whatever, which I think to your point, Arlene, they have to be a little more forward thinking and say, no, these are cost savings.
Think outside the box. Think outside that box.
Absolutely. And thankfully, hospice, we got an increase this year, but we've got sequestration and we've got inflation, and I think it's net zero at best for most organizations. And so
better than home health, though.
Yeah, right. Better than home health, absolutely. But it's a wake up call, right? For hospice organizations. The Medicare Trust Fund is is empty and fast. And we, everyone, then there's not a sacred hospice. We're not going to touch that anymore.
Yeah, and so you were saying that earlier, the Medicare Trust Fund, if the numbers for hospice haven't really changed, I think one of the bigger concerns that we're having, and I'm glad that maybe CMS is coming down harder on hospice, making it harder, especially that 3-year rule, so we're not just switching hands, flipping hospice, is that about only 50% of the people that need hospice use it, number one. Mm-hmm. Number two, if they do use it, the average length of stay is like 9 days, something like that overall. Yeah. So you have potentially, on days, maybe almost 200, 300 days of an annual budget that we're not even touching, right? What happens when now we see home health companies actually leaving the market since 2014, they're declining, right? We're going to see more people shifting to hospice. We have access to podcasts like this and other things where people are like, oh, okay, hospice is a good thing. Where are we going to get the money to pay for it? I mean, because it's not a small amount of money, $30,000 per patient, and we're barely hitting, $5,000, not even per patient.
Yeah. I mean, it's a huge issue, right? And so I think I would say that hospice organizations really need to understand CMS health equity initiatives now, and they need to start putting things in place, because when you talk about growing your business, right? We don't have to go up and out. We shouldn't just be going and hitting up our referral sources and physicians and doctors. We should really be looking at the communities that we serve, right? Because there are large numbers of underserved people in every community, and that's how good hospice happens, right? It doesn't happen when we start a hospice, and we get it up to 20 patients and we sell it for $75,000 per patient. That's not good hospice care, right? That's what's happening. But what happens is, good providers really dig in. They find, technology and other innovations and ways to survive and even thrive, and kind of get back to where hospice was a long time ago. I mean, it's always going to be a business, but let's bring it back to the patient-centered care that it's always been.
And I think that there's a real problem too in identifying these patients quickly enough. You're saying that you have the average length of stay is 9 days or something like that. We have to identify those patients when they need the hospice, because sometimes we get them at the tail end. What was it? Jimmy Carter's wife had it for a day.
Oh yeah. And honestly, at first I was so excited. I was texting everybody, look, she's on hospice. Great. It's great publicity for us. And then it was like 2 days later, boom, not on hospice anymore.
Well, he's still on, and he's been on for a very long time. But this is a really good segue into palliative, because I do believe palliative care can be that bridge between the home health services. Of course, some home health services offer palliative, can be that bridge where we can identify those patients earlier when they actually need to go into hospice care. So can you talk a little bit about palliative? I know a lot of people have different ideas about what palliative is, but basically, how are you identifying it? And do you think that that's a really good bridge to getting these folks into a hospice at a better time than 9 days or 1 day before they expire?
Right, 1 day before. And I will say about Rosalind Carter, I was really excited. And then I was like, oh, she died. But then I realized that she had dementia. And if you look at the LCDs for dementia, someone has to be very near death in order to qualify for hospice under a dementia diagnosis. So I was like, well, they got it right, sounds like. However, I think we've always had there's always the difference between curative care and comfort care. And we know our healthcare system is driven by making people better and healing them, right? And finding that cure. And hospice is a little different. We're going to take good care of people. We're not going to use all of the curative treatments and modalities that are out there to help someone get better. But, nurses and physicians, by and large, go to school because they want to help people get better. Right. And so before I start palliative care, there's a lot of provider education that needs to happen. Most physicians are hesitant to refer a patient to hospice, right? Because that's their patient and they don't want them to die, right? They want to figure out.
Right. They have a hard time with that. Doctors have a hard time with that.
They do have a hard time with it. And so, but I think from a home health perspective, palliative care, from any perspective, really is a really nice bridge. And I think really thinking about community-based palliative care, because we're talking home health and hospice, right? Identifying patients that have that chronic illness early in their diagnosis, or when they come on home health services, I think they could really benefit from palliative care. And palliative care is more than just going out and, meeting the physical needs of the patient, right? Palliative care is really designed. Yes, we want to provide some comfort. We want to help relieve stress caused by the illness. So whether that's the patient stress or family stress, right? And then, of course, really kind of serving as the hub of communication for all of the different providers. I mean, if home health, they had somebody who was on palliative care concurrently, and that palliative care person was talking to every different specialist that this patient has ever had, even though, home health may be just talking to their cardiologist, right?
Yes.
They can really do a lot of that legwork, do some of the legwork as far as community resources, finding ways to help relieve that stress. It's really just an add-on benefit for someone who's chronically ill, right?
In my experience with palliative patients specifically, I think one of the issues that arises both from home health and hospice, mostly on the hospice side, is that palliative patients are extremely active compared to most of your hospice patients, and they tend to be high need, high communication, right? Because they're in this transition period, and that can, if you're not set up for that, it can be very overwhelming. A lot of phone calls, like you said, a lot of communication, a lot of back and forth. And so I find that it's almost not care fatigue, but communication fatigue from the company. Have you seen that?
Absolutely. Right. Because these are people who are receiving care, maybe they're on home health, possibly, right? They're receiving care in their home. They're still seeking curative treatment. They've got a lot of things going on. Maybe their adult children live away out of town. There's just so many different variables that require that extra level of communication, and someone who's really highly skilled at care coordination, quite frankly. I talked to someone a couple of weeks ago, and they're using community health workers to really support their palliative care efforts, right? Because they can talk to the families as well as, have that professional conversation with the involved providers. And so I think that really understanding the value of that communication, right? Because as the patient progresses, maybe they're getting better. I think that seeing that as a value rather than I'm so tired of talking to these people. And I'll just tell you, I'm a responsible party for a hospice patient right now. She worked in hospice for a long time. A few weeks ago, I talked to her 17 times in one day.
Mm-hmm.
Yeah.
17 times.
Yeah.
And that's what, hopefully that's not what all families go through, but, and that's an extreme. However, she knows.
If you're the responsible party, though, too, it maybe calls in just off the top that you might be the closest, only, whatever is the bigger family, the bigger group of people you have to call. If you have 17, if she had 17 people to call, she might have only called you once.
Right.
oftentimes, especially with our elderly patients, it's a very limited number of people that they know, trust, and want to communicate with.
Yeah, and again, and I know you guys have probably experienced this before. I mean, what do people do that don't know about home health or hospice or the healthcare system in general? I mean,
it's very hard to get through it. It's really hard.
And I think, that's something to think about from, a training perspective, right? For providers to make sure that, they understand that, but also that they're providing as much education as possible in a difficult time for hospice patients specifically about, this is what's going to happen. This is, what it usually looks like, and kind of give them that primer early on, so they don't feel like it's out of control.
I don't know how many viewers have heard about this, but CMS has just started, and I think the application's going this month, something called a guide program. And you mentioned earlier about dementia patients, how hard it is to admit to hospice. This guide program, in fact, somebody from an NHPCO was saying that they see this guide program as being almost a palliative hospice, quote unquote, program for those dementia patients, because there really is so little out there to care for some of these patients. And
they're some of the most vulnerable, and their caregivers are the most vulnerable.
There you go. So the guide program is going to be available. It starts in June. I would encourage folks to look that up. Maybe we should do a session on that, John, on that guide program. In fact, I would love to get that person from NHPCO to come on and talk about that, because she was the one that was, I think her first name was Rory. Is that
Rory? Yeah, I know who you're talking about. Yeah, I know her. Yes.
She was talking to one of the CHAP surveyors about how they're really excited about this program, and how that could be a huge benefit for some of the. I've experienced with my mom had dementia for 15, 20 years and died from that, and I know how. I mean, it's just horrible. I mean, and it just goes on and on and on and on, and it's just so difficult to manage.
Yeah, and when we're talking about hospice and getting them on service, there's nothing harder than having to tell a family with dementia that we can't service them, especially after we did such a great job on selling them on the service.
Yeah.
Right. I mean, we always try to temper everything, make sure we never promise and over deliver, but you're the saving grace. You're the peace that's coming to some of these families that have no support. And we're right there at the finish line, and we go, hey, congratulations, they're not quite appropriate. And they're like, what? Like, oh my gosh. Like, but again, that's where like a palliative program could come in. But where do you see it best fitting? Is it a standalone program, in your opinion, standalone program is what it should be, billable on its own, connected to the home health, which is right now the bigger part of it, right? Or should it be connected to the hospice? I've thought about this a lot over how you can get it. But I know right now the reimbursement is just not, very, I guess, aggressive, or, there's not a lot there for a lot of people, right?
Yeah, so I actually have a friend who is a hospice physician here in Texas, and recently retired from a hospice. They've got about 350 patients. They've got about 400 palliative care patients. And what they've done is really beautiful. They have full-time providers. So they have full-time physicians, 2 physicians, 2 nurse practitioners, maybe 4 physicians and 2 nurse practitioners, but they're able to go out and see the palliative care patients, right, as a billable visit under Medicare Part B, but they're also able to go see the hospice patients for face-to-face recertification and just those visits. They've got a general inpatient unit. Now I will say they're a nonprofit, so they have lots of resources to do that. But it kind of really is a beautiful thing. I think that once home health and hospice providers really start to understand the Medicare Part B component and the fee schedule, because that's something we don't know anything about.
Yeah, I know.
Once you educate yourself, you can really see where, hey, we're not going to make a lot of money off of this. However, we could improve our patient care maybe by having a nurse practitioner on staff, right?
And I think at the end of the day, the more time that we have with these patients, the more opportunity for us as a good organization. I'm talking only good organizations here, because the opposite would be true. But the more time you spend with the patient, the patient's family, the more become, we have patients that when they're on 30, 60, 90 days, we become family. You know what I mean? Like that we are almost as devastated, and I say that humbly, as the family is with the passing, where my nurse is calling me and she's crying because, that family had, just touched us as much as we tried to care for them and provide for them. So palliative care in a lot of ways is really a good emotional setup for that, journey, that last stage of life to get the family and the patient ready together to say, yeah, we're ready to do this together. And there's nothing worse than a family and a patient that is at odds of what hospice is, because it makes the service not as good as it could be, right? Because we're there to take care of everybody.
Right. And so we really talk a lot about developing confidence with our patients in hospice and their family members, right? And those late referrals where we just have them on for a few days, we don't get a chance to establish that relationship and the associated confidence with them. But with palliative care, being able to come alongside the patient so early in their chronic disease process and stay with them, through home health, maybe to hospice, until it's time for them to go to hospice. Talk about having somebody who, just has a great relationship, right? And it helps us as providers. So, to know that there's somebody that's still with our patient, right? No matter which way they go, that one common touch point. So, and I will also say just real quickly, with the extension of the Medicare Advantage value-based insurance design as it relates to hospice, hospices that provide palliative care services are already one step ahead of hospices who do not. So, there's lots of business cases for palliative care outside of the revenue or lack thereof. But I think it's important to consider it, whether you're doing home health or hospice, to think about palliative care, because it's such a needed service and it's going to continue to grow.
Yeah, absolutely. I was thinking, as far as, oh shoot, I lost my train of thought.
That's my job.
You were saying about, oh shoot. Anyway, I don't know. I'll remember now. We're getting kind of close to the top of the hour anyway, and we've already gone through a lot. But that's what I was going to say. So as far as technology goes, I know you work for Axxess. We're talking about, SFP, making sure we have good data coming in, making sure that we're in compliance, making sure we're ready. We're talking about how to connect with people, different things like that. How does Axxess or a good EMR play into the overall outcome of these sort of things that we're talking about versus maybe somebody that, it doesn't have all the features, or, globally where, nurses are having to do, most of the documentation. It's not easy.
Yeah. So it's important for, the EMR to really be a partner of a hospice organization or a home health organization, and I was fortunate to be able to be on the team that originally developed Axxess Hospice. And so I'll tell you,
I use it.
Oh, good. Yay. So I'll tell you what I would suggest organizations do when they're evaluating their processes, right? And how that fits in with their EMR. They need to get out the conditions of participation, specifically the state operations manual, and they need to go down the list and they need to say, does this EMR do this? And does it do that? Right? That's fundamental to making sure that, because if it doesn't have basic compliance, you're going to have lots of workarounds and lots of issues just trying to be compliant. And it should be a partner and should make things easier, right? And not more difficult.
I got to say just one thing before we close out here. I had the opportunity to look at some hospice organization was going through an initial survey. They wanted me to take a look at clinical records to see if I could find any deficiencies. I found one. They were using Axxess. I found one that they were able to correct before the surveyor even asked to look at records. The surveyor found like 2 minor deficiencies that the EMR could not have corrected. It was a clinician mistake. I was so proud to say that I was part of an Axxess team and having something, an EMR that was so clear that it's so easy for QA to be able to identify a problem with either documentation or dates or whatever it is that they have. The IDG meetings were absolutely perfect. It was absolute perfection. It's an incredible system, and you deserve a lot of credit, Zaundra, because you put a lot of work in that. And I know that was your brainchild when you first started with Axxess, and that's an incredible system. It is.
Well, thank you. And I just appreciate you sharing that, right? Because, that's what we're really going for. And in the original development of it, our little core team that was working on it, we really wanted IDG members or hospice employees to think, with every keystroke, they thought of me, right, when they did this. And so from the way it looks to the way it functions, right, it's hospice specific and, really the honor of my professional life to play a small part in that. Yeah.
Well, yeah, it's great.
How small that was. It was a pretty big part. Sorry, John.
Yeah, I'll ditto on it. And I'm no clinician. I'm not a clinician, but I love to make sure that our team members, the people that I work with, they have the best job that they can possibly have. And documentation, the EMR is the bane of every nurse's existence. Yeah. Right. Like, you go to school to take care of people, not document how to take care of people, right? So when documentation becomes 50% of your job, you're 50% unhappy every day. Right? And those are not good statistics for us in the labor shortage that we have. So my big impact for me, why I chose Invoke, why I chose Worldview, why I chose Axxess is, these technologies, right, that aligned with not just better care, not just better compliance, but what's going to make my staff happier. What's going to get them home with their families at 5 o'clock doing family stuff, not on the computer, not documenting, 3 months later or whatever, a month later or 3 weeks later because they just don't want to touch it. Yeah, you can't do 3 months. But
no, don't say that.
Yeah, but delaying the inevitable because they don't like it. That was always my mindset. It's like, why are we pushing this? And I've been a part of so many agencies that are like, oh, well, this is what we're going. This is what we're doing. Like, but nobody likes it. But we don't care. This is what we're doing. It's like,
yeah,
we're never going to grow that way because without a happy staff, you'll never grow your patient bases because your patients won't be happy.
Correct.
You just can't do it.
Correct.
But yeah, I think that's so much of a part of it is just ease of use for your staff so that they feel like, their job isn't consuming them. So they get to give more to those patients. So
yes, absolutely.
Awesome.
Zaundra, it's just been an absolute pleasure to have you on here today.
Yes. Thank you so much.
I think everyone's gotten so much out of this, and it was free. They didn't have to even pay for it.
Yeah.
Well,
and I have a feeling we're going to be having you on again, just because there's so much that is changing with hospice. We didn't even get into half the stuff that's probably going on, but right now I think we did give quite a bit of information on the SFP, a little bit on palliative. And if anybody wants to reach out, maybe have offline conversations with you, how would they be able to get a hold of you? Just if they wanting to talk about Axxess or any of the stuff that we discussed.
Probably the best way to do it is shoot me an email. So it's Z as in zebra, ELLIS at Axxess, AXXESS.com. That is the quickest way to get in touch with me. And so I want to thank you guys. It's been so much fun. I'd love to do it again.
An hour flies by, doesn't it?
It goes by quick.
Yeah. Well, thank you so much. And I appreciate everybody watching that was live on LinkedIn, on YouTube. If you have the opportunity, go on YouTube and subscribe so that you'll know when we have these upcoming events. We're going to try to be also spreading our tentacles out there on the intraWebs. Arlene is leading the charge. She's the social media guru. She's always coming to me. I don't know how to do this, but we're learning all this together, and it's always an honor and a pleasure just to come out and get to talk to y'all. So thank you for watching, Zaundra. Thank you for coming, and Arlene, as always, thank you for being amazing. Guys, this is another episode of Off the Cuff, All Things Healthcare. We'll be back next time. Thanks.
Bye.
Bye.